Once again, good morning, colleagues. I want to emphasize your attention on the atypical and anaplastic meningiomas. Usually the irradiation or stereotactic radiosurgery for benign meningiomas, as it was told by previous lectures, is very successful, but there is a lot of difference and for atypical and anaplastic meningiomas. Also, there is some not very clear situation, which I will show you later. At the beginning, I want to say that the meningiomas arising from arachnoid cup cells, and they can arise in any place where they are present. There is the most common non-glial primary brain tumor. It's amount for 20–30% of intracranial neoplasm. Annual incidence 6 per 100,000. Peak incidence is around 60–70 years. 2 times more common in females because there are few hormonal factors, female predominance. Genetic factors also, the neurofibromatosis NF2 tumor suppressor gene found in a large portion of meningiomas. Sometimes there are some suggestions of increases risk meningioma following head trauma, and also we don't need to forget about radiation-induced meningiomas, which are the most common radiation-induced tumor in head, and after previous irradiation in childhood, 0.5% is the risk of this radiation-induced meningiomas, and they have a higher rate of atypia compared to sporadic meningiomas. As was mentioned earlier, there are a lot of places of arising this tumor in central nervous system. There are the 90% meningiomas that occur supratentorially, but also we had to remember that the 1% of meningiomas can occur outside the CNS. And there are some changes in this classification. As usual, we know that the and previous lectures mentioned that the typical meningiomas are up to 90%, atypical 5–7%, and anaplastic meningiomas 1–3%. This is according classification 1993. In 2000 and 2007, World Health Organization revisited the pathological grading of meningiomas using the combination of objective criteria, mitotic index, and subjective criteria. And their classification has resulted in higher percentage of meningiomas being classified as atypical. And we can compare these studies. If we use the previous criteria, 1997, the amount of atypical meningioma where at the series of 900 meningiomas was 4.7%. And if you use the criteria of 2000 or 2007, the amount of meningiomas can arise more. There are some differences of these classifications, and you can see that in 1993 there were only the suggesting that the frequency necrosis, increased cellularity, and for grade 3, the histological features of frank malignancy. We have a lot of such description still now from our pathologies. But more modern, we want to ask them about the number of mitosis in the high-powered fields. If there are 4, it can be more than 4, it can be the grade 2. If there are more than 20, it can be the grade 3. And also there are some changes in brain and also the necrosis. And the difference between 2000 and 2007 is that the brain invasive became the feature of the grade 2 meningioma. Also, there are more than 4 mitosis in 10 high-power fields, and for grade 3, there are the 20 mitosis per 10 high-power field. We can see this pathomorphology, the brain invasion. This is here mitosis zones of necrosis, and also this, as was mentioned earlier, high proliferative index Ki67. As for diagnostics, one of the main features of the, which we can see by MRI, is the dural tail. It's can be occurred at 72% of cases. They are well. We can see the well-enhanced homogeneity. Also, one of the most important is CT imaging for these meningiomas, because we can see bony changes in up to 46%. Also hyperatosis, also calcification. This we need for treatment planning, especially, and for radiation treatment. What treatment options for treatment of atypical and anaplastic meningioma? Yes, of course. The main is the prognostic factor, as we will see later, is the maximum possible microsurgery. Also is the radiation treatment. Effective chemotherapy, there is no effective chemotherapy for example, we speak about anaplastic meningioma. Observation, radiosurgical surveillance. Yes, and the goals of radiotherapy, as I told earlier, local control and normal structural protection. Yes, there are the NCCC guidelines, and we can see all these facts, as we told earlier, that there are the asymptomatic and symptomatic meningiomas. And when we see for grade 1, the main after surgery, the main option is observation. For grade 2, for asymptomatic tumors, for grade 2 is with complete resection. Consider radiotherapy. And for with incomplete resected radiotherapy, we need radiotherapy. For grade 3 radiotherapy, we need in all cases. Here we see in symptomatic, this point I saw that the grade 1 and grade 2 also mentioned in this in the cases of symptomatic as the possible consider for radiotherapy. In the cases of relapse of tumor, of course, it can be surgery. If and after surgery, we need also radiotherapy or consider the irradiation. If the tumor not surgically accessible, we need radiotherapy. But in cases when there is not surgical accessible and radiotherapy is not possible, maybe there are some treatment options by chemotherapy, and here there are recommendations by NCCM, the interferon alpha, somatostatin analogs, and sunitinib also. Yes, and let's return to surgery. Surgery, as was mentioned earlier, that there is the most predictive factor of overall survival and progression-free rates of these tumors. Of course, this is the we can compare for well-known grade, Simpson grade. If it is complete removal with dural attachment, the rate of recurrence is nearly 9%. And in cases of subtotal removal is from 90% up to 40%. You can compare the local rate in a years, even it was not removal completely. We can see this statement as I told earlier. Also, the great role play the post-operative neurological deficits, as Dr. Tulescu told us about the possibility of total removal of this tumor. Their total is actually from 20 to 80%. And the post-operative neurological deficits can be up to 86% in the very critical structures. And however, the maximal safe resection should be the most appropriate strategy than gross tumor resection, that the surgical morbidity can take the more. Also, the recurrence rate very depend on the grade of this tumor. And the malignant histology is associated with poor prognosis. We can compare this by literature, that compare the gross tumor resection and subtotal resection. There are a lot of studies, a lot of papers, and the 5-year progression-free survival after gross tumor resection is also high. Nearly, I mentioned the 59%, but nearly 80-90%. But after the subtotal resection is only 30-70%. If we yes, here is I show this tape. What about this? We speak about atypical meningioma, grade 2. What about external beam radiotherapy after this treatment? If it is only gross tumor resection, it can be controlled in 65-96% for 5 years. But if it is adjuvant external beam radiotherapy, in some series achieved for 100% of 5-year local control for this tumor. And of course, if we make it, for example, in this table for these studies, after we see that for grade 2 meningiomas, it can be simply the low rate of this progression-free survival compared with those who have after surgery external beam radiotherapy. And here is proposal algorithm. I will say for you that because maybe there is no clear for atypical meningioma. If it is a primary tumor, it's the same as NCCM, the gross tumor resection. And if it is the brain invasion, if it is the mitotic index more than 8, we need to consider about, we need to have external beam radiotherapy. This is evidence-based level 3. If it is recurrent tumor, we need also to resection, salvage resection, and as external beam radiotherapy or stereotactic radiosurgery, and also look and surveillance for this. What about anaplastic meningiomas? This is the prognosis is more poor than in atypical meningiomas, and the salvage the progression-free survival and overall survival 5 years after gross tumor, subtotal tumor resection, after adjuvant external beam radiotherapy and salvage SRS is from 0 to 27%, and overall survival 33, 61% in these cases. Also, we need after gross or near gross tumor resection, we need adjuvant external beam radiotherapy. In cases of recurrent, it can be salvage resection and also salvage radiotherapy, radiosurgery as an irradiated for these cases. There are the patient selection for this for external beam radiotherapy is the residual tumor after surgery recurrent, and clinical tumor volume, and there are some safety margins for all types of these tumors, including also in the resective cavity. For atypical, usually it can be 1 centimeter safety margin, and for anaplastic, it can be 1 or 2 safety margins. For external beam radiotherapy, PTV, 1 or 5 millimeters, depending on radiating technology. The doses for this treatment, for benign tumors, big tumors near anterior visual pathways, it can be 50 grays in 25-30 fractions. But for atypical, it's had to be no lower than 55 grays for gross tumor resection, and 60 grays for subtotal resection in 30 fractions. For anaplastic meningioma, it had to be 60 grays or even up to 66 grays for in satisfaction, but we need to aware of possible complications of this. But what about stereotactic radiosurgery? Yes, it is not so option as for benign meningiomas, and of course, but we can treat it by also different machines, and the indication are for elderly patients, for some critical structures where we can make the precise treatment, but also in cases of radiotherapy it's not so very good results as in benign tumors. And the role in radiosurgery is, we can see the margin dose in these cases. It can be really, in sometimes can be as high as possible. And there is one, usually in all cases there is around 15, 16, 18 marginal dose. But there is, I want to emphasize this, in one paper by Kane, we can see that escalating of the dose up to 20 grays, more than 20 grays in the case of single fraction radiotherapy, can increase progression-free survival rates as we see, and this. But after analysis of this data, I saw only this one patient by Kenner for 2007. In another studies, the main predictive factor is mitotic count, and if it is more than 8 in high power field, mitosis or something features of atopy, anaplasty, the prognosis is more poor. And for fractionated stereotactic radiosurgery, there are only few papers, one of this from Stanford. They use the average doses 25 grays in 5 fractures in the same nearly. There is no significant difference between grade 2 and grade 3 for these tumors. And we can see that for these tumors, for grade 2 meningiomas margin doses, it's had to be 16 to 20 grays, maybe safety margins, 1 millimeter. For meningiomas, grade 3, safety margin for radiosurgery, for hypofractionated radiosurgery, it can be 2 millimeters. But we need to think about the high risk of complication because of previous external beam radiotherapy. Speed growth, very fast growth, and big size of the tumors. We have 22 patients with meningioma. Among them were only 2 patients with features of atypical meningioma grade 2. There was one patient with, I showed you yesterday, with cranioorbital meningioma and also grade 2, and the prescribed dose was 25 grays in 5 fraction. It was good for. I suppose that we will control this tumor more. Also, another patient was with atypical meningioma in the level on sinuses, and after the surgery, incomplete surgery, also the dose was prescribed for, but it was also the neuronoma in this case. Also, there was prescription for 25 grays for these tumors. This tumor. There is some differences. This is another case. This is not grade 2. This is not atypical, but it is meningiomatosis. It can be also, we can be different, and in these cases we also prescribe the dose. And I want to show you, this is not about meningioma, but about anaplastic schwannoma. The tumor with grade 3, which we treated here in Sigulda. He was treated, there was surgery. I think it was the complete removal of this tumor. It was adjuvant external beam radiotherapy in 2010. He got 58 grays radiotherapy, but it was after 7 years, it was the relapse of this tumor, and we made irradiation in 14 grays for this. Thus, at the end, I want to say that the most predictable factors are the histological grade, incomplete surgical resection, previous radiotherapy, also maybe the large size, and then these points. And we can say that external beam radiotherapy or stereotactic radiosurgery plays a very important role in treatment of this patient with grade 2 and grade 3 meningiomas. And we need to ask our pathomorphologist to say us about this precise, is it grade, what grade in these cases, especially in the cases where suspected brain invasion and some. Well, thank you.